So just like Julia said, I've worked in different NGOs in Nigeria before coming to the US. And while I was working with Doctors Without Borders, I was also doing my PhD program. And while I was working as the mental health supervisor, there were a lot of things that I saw because I was working as a supervisor and also supporting my staff, somehow like an adjunct staff psychologist. So that was how I was able to draw some ideas on how to go about this research. I observed a pattern of difference in the presentation of symptoms from the humanitarian health workers that I was supporting at that moment. So I began to look for trends, patterns, connections, things like that were just familiar to humanitarian health workers. We all know that even within the humanitarian sector, not everybody that works there is actually a health worker. And my research focused on humanitarian health workers, specifically counselors, psychologists, doctors, nurses, those who see patients on a daily basis. So I observed that the presentations from the humanitarian health workers was slightly different from the presentation of those who were humanitarian workers, but who were actually maybe from admin, from supply, from maybe HR, from logistics, those other departments that we have in the humanitarian sector. So I began to find trends and connections, similarities among these humanitarian health workers. So I discovered that majority, almost everyone presented with related mental health problems, but the causative factors, the predispositions, the triggers were a bit different, especially for humanitarian health workers. And I began to discuss this with my supervisor, and we all agreed that, okay, let's try to look at some of the factors that may predict the mental health of humanitarian health workers. So I wanted to look at the role of secondary traumatic stress on the mental health of humanitarian health workers in Northwestern Nigeria. And not just that, to look at some of the protective factors that can be strengthened for us to be able to help humanitarian health workers, such that irrespective of the fact that they continue being exposed to this secondary traumatic stress, they will still be able to experience some level of positive mental health and continue with the work that we're doing. So that was how the whole idea of examining secondary traumatic stress and psychosocial well-being among humanitarian health workers in Northwestern Nigeria. And in the original research, I actually examined the moderating role of two variables. One was interpersonal resilience, and the other was hardiness. However, after I finished the research, I was able to draw two papers out of the research. And it is one of those papers that I'll be presenting the findings from that paper that I'll be presenting to you today. That is why you see my presentation here on the first page is showing the moderating role of hardiness. So the work I'm presenting to you today is one of the papers I published on the moderating role of hardiness between secondary traumatic stress and psychosocial well-being. So I'm not going to bore us with some of these operational. I just want to give us a background of what inspired me to carry out the research. I believe we all know what psychosocial well-being is, secondary traumatic stress, humanitarian workers. We are conversant with some of these terms. So I will just move straight to the aim and objectives of the study. So specifically in the research, I wanted to look at how secondary traumatic stress affects the psychosocial well-being of humanitarian health workers in Northwestern Nigeria. And this secondary traumatic stress was tested in 3 ways. Secondary traumatic stress, according to the scale that I used in my study, has 3 dimensions, which are similar to the 3 major symptoms that we see in PTSD, because it's a form of trauma. So there are intrusions, there are avoidance, there are hypersensitivity. So I wanted to see how those 3 dimensions of secondary traumatic stress affect psychosocial well-being. I also wanted to look at the influence of hardiness. Hardiness is a form of kind of personality trait. It's made up of 3 dimensions as well. It measures control, it measures challenge, it measures commitment. So one of the objectives was to see how these 3 dimensions of hardiness also affect the psychosocial well-being of humanitarian health workers. The third objective was to look at how hardiness can serve as a protective factor, like a shield, whether it moderates the impact of secondary traumatic stress on psychosocial well-being among these humanitarian health workers. And then lastly, I wished to look at how both secondary traumatic stress and hardiness together, jointly, how they influence the psychosocial well-being of humanitarian health workers in Northwestern Nigeria. So the study was specific on mainly humanitarian health workers, such as counselors, psychologists, doctors, health promoters. The reason was because not everyone had access to clients. When you talk of secondary traumatic stress, we're talking about that secondary, like you are not the primary target of the trauma, but because you are helping as a psychologist, as a doctor, as a nurse, you are supporting people who are internally displaced. You are supporting people who are maybe victims of malnourishment, victims of GBV, gender-based violence, victims of maybe some kind of outbreak, disease, surgery, patients with different kinds of ailments and traumatic experiences that you are supporting them on a daily basis. So hearing these stories, supporting them, offering, at some point, empathy takes you to a level that you begin to feel the trauma as if it actually happened to you. So the target of this study was to examine the secondary traumatic stress among only those health workers who are exposed to clients on a daily basis. So they were the ones that formed the inclusion factor for the study. So the study covered about 2 years, from 2023 to 2025. So in terms of the design for the study used cross-sectional survey design. I used this design for the study because the aim of this study was to collect the opinions of humanitarian health workers across different sectors, different NGOs, different states in Northwestern Nigeria with different attributes, different presentations, looking at supporting different clients in the humanitarian sector. So the aim was to collect data amongst them at one point in time. So the correct design that would be able to support me in doing this was cross-sectional survey design. So in this study, I looked at secondary traumatic stress as the predictor variable. The outcome variable was psychosocial well-being, and the moderating variable was hardiness. So the study was conducted among about 3,212 humanitarian health workers in Northwestern Nigeria. Northwestern Nigeria actually has about 7 states. Yeah, it has 7 states. And all the 7 states were considered in the study. So what we see on the screen is the number of humanitarian health workers in each state, according to the 7 states that we have in Northwestern Nigeria. So in order for me to determine a representative sample that I could use for my study, I use the Dillman's formula to be able to do that. In research, normally we have a large population, but at times it's not just possible to kind of assess or do your evaluations or assessment on the entire population. So having a sample that have those representative features of the original population helps to keep you in control and also gives you valid results that can be generalized on the general population. So I used the Dillman's formula to draw 344 participants, which formed the sample for my study. So in terms of the sampling technique, I actually used a multi-stage sampling technique to be able to draw the sample for the study. So when we talk of multi-stage sampling technique, we are talking about a sampling technique where there are multiple stages. When you want to draw the samples of your study, the sampling exists at multiple stages. Maybe at stage 1, you use this, stage 2, you use this kind of sampling technique, like that. So what I did in my study was that since my study was covering like 7 states in Northwestern Nigeria, I used a census sampling at first to consider all the 7 states in the study. So at the second stage, since my study was focusing mainly on humanitarian health workers, not just all the humanitarian health workers, I was specific on humanitarian health workers because of secondary traumatic stress. I used a purposive sampling to ensure that it's only humanitarian health workers that I used for the study. And since the study used different NGOs who were supporting at that moment in Northwestern Nigeria, I used proportionate sampling. The reason why I used it was to ensure that NGOs have different numbers of staff or humanitarian health workers supporting in their organizations. So proportionate sampling actually helped me to like draw more samples from NGOs with higher populations of humanitarian health workers. That means that NGOs that had a lower population of health workers, a lower sample was drawn from there. This is just a summary, so I couldn't present all the figures for you to be able to see. So at the last stage of the sampling, multi-stage sampling was a simple random sampling technique, which I used directly to ensure that the participants are given equal chance of being chosen to participate in the study. So that was how I was able to use multi-stage sampling to draw the sample for the study. Okay, so in terms of the participants I already said were 344 humanitarian health workers, and amongst them, 208 were males, 136 were female participants. So I used 3 instruments for data collection in this study. The first instrument I used was the secondary traumatic stress scale, which I used to assess secondary traumatic stress. The scale has 3 dimensions, and it has very good validity coefficient and reliability coefficient, which it's very good, 0.7 and above. I used the hardiness scale to measure hardiness in the study. Hardiness also has 3 dimensions, which I already mentioned, and it has a very good validity and reliability coefficients. I used the Copenhagen psychosocial wellbeing scale to collect, to measure psychosocial wellbeing. This scale also had a good reliability and validity coefficient. So these scales were actually developed by authors from different countries across the world, validated in those countries somewhere else away from Nigeria. So for me to be able to use these 3 instruments in Nigeria, there was need for me to pilot to see how feasible these instruments can be to help me measure the variables that I have in my study. So I used a sample of 117 humanitarian health workers from 2 NGOs in Sokoto State, which is one of the states in Northwestern Nigeria. So I ensured that these 117, which were used for the pilot study to test the instruments, they did not constitute the participants for the main study, so that history doesn't affect the responses that we have. So the result of the pilot study indicated that the instrument had a very good coefficient. Reliability was more than 0.70. The item total correlation was more than 0.30 according to Cristobal et al. 2007, which indicated that all the 3 instruments were good for use for the main study. So I proceeded with that. Basically, the procedure for the study is just like I've already stated. The study was conducted in the 7 states in Northwestern Nigeria. I went ahead to seek the approval from all the NGOs. The approvals were given. It involved a lot of stress and hurdles to be faced. It took time, but at the end, the approvals were issued. And then I was able to connect with a network of NGOs in the Northwestern region. So it was easier for me to communicate with them and then get the support I could get to be able to carry out the study. So the administration of this questionnaire was actually done this way. The administration of the questionnaire, since it was a cross-sectional survey research that I did, the data collection was not done physically like using direct questionnaires on paper. However, I converted the physical questionnaire into an online Google form, since I used a lot of NGOs. There were a lot of humanitarian health workers involved, like over 304. And I was the only person. It wasn't like a funded study, or I'm collaborating with other authors to other researchers to do that. So it wasn't easy. So since I was also working and also doing my research work, it was more easier for me to use the Google form and then communicate with other organizations for them to support me, for me to be able to administer the questionnaires virtually. So this was actually achieved with the help of the HRs from all the NGOs that were used in the study. So it actually took like 2 months for this to be completed. It was a long process. I kept on reminding the HR, the HR kept on reminding the participants in their organizations consistently every week. And at the end of the day, the responses were all recorded. I was able to monitor this from my Google account as the responses were coming in. So once everything was intact, I proceeded to download the Excel sheet and then convert it to SPSS, which I used for my data analysis. So the data for the study was analyzed this way. I used both descriptive statistics and inferential statistics to be able to analyze the study. The descriptive statistics were used to describe the participant in terms of maybe their age, the mean age, standard deviation, the frequencies of their categorical attributes, like their sex, marital status, etc. We use our frequencies and simple percentages to be able to express that, which the figures we actually presented in the main work. So I also used inferential statistics to be able to test how secondary traumatic stress and hardiness, how they interplay with the psychosocial well-being of humanitarian health workers. So statistically, I use a multiple linear regression to test secondary traumatic stress on psychosocial well-being. So the reason why I use a multiple linear regression was because it's a form of regression, like linear regression, testing one independent variable on the outcome variable. But because I was considering the dimensions of secondary traumatic stress, like the intrusions, the avoidance, the hypersensitivity, which are the 3 main dimensions of secondary traumatic stress, I had to use multiple linear regression to be able to take into consideration the dimensions and what contributions they each have in predicting psychosocial well-being. So that was the same thing for when I tested hypothesis 2, which tested the role of hardiness. Hardiness also has 3 dimensions, which includes control, commitment, and challenge. So I used multiple linear regression to see how those 3 dimensions also contribute to predicting psychosocial well-being among the participants. So I also use Hayes process macro moderation analysis to test how hardiness moderates between secondary traumatic stress and psychosocial well-being. So lastly, I looked at how the joint influence of secondary traumatic stress and hardiness on psychosocial well-being among humanitarian health workers. So this is just a summary of how the data analysis was done for the study. So in terms of the results, I presented these results here without the figures, just to give us straight access to the key findings that were obtained from the study and not necessarily boring you with all the figures involved in it. So very simply, the findings of the study were promising and useful. I discovered from the study that secondary traumatic stress and all its dimensions had a negative influence on psychosocial well-being. This could mean that since the relationship was kind of negative, it means that high levels of secondary traumatic stress predicted lower levels of psychosocial well-being. The result for the second hypothesis indicated that hardiness significantly and positively influenced psychosocial well-being. So since the direction of influence, since it was positive, it means that high levels of hardiness were associated with high levels of psychosocial well-being. Result number 3 indicated that hardiness significantly moderated the relationship between secondary traumatic stress and psychosocial well-being among humanitarian health workers. So this actually indicated the implication of this finding is that hardiness can serve as a moderating factor, a protective factor, a kind of shield that protects humanitarian health workers from poor psychosocial well-being, irrespective of their exposure to secondary traumatic stress. So lastly, there was a significant joint influence of both secondary traumatic stress and hardiness on psychosocial well-being among humanitarian health workers. So in terms of the recommendations for the study, the findings from this study were very promising, and based on the findings, I recommended that I also observed that a majority of NGOs were not currently having a staff psychologist supporting their staffs. And the mental health of humanitarian health workers is very important, and it has to be supported at every point. So having this result, I made recommendations in the study that NGOs should ensure that that position of staff psychologists should be very key for all NGOs. They should employ clinical psychologists who will serve as staff psychologists. And these staff psychologists should also work on developing policies that will ensure that since humanitarian health workers are exposed to secondary traumatic stress, which is a daily part of their job, and a lot of factors can play a role in predisposing them to being a victim of this traumatic stress. There should be occasional assessments, maybe periodic mental health assessment that should be just part of the organizational policies to monitor and regulate the well-being of humanitarian health workers, so that once they begin to move out of just normal distress to maybe abnormal levels of stress, they can be supported, and they can get the necessary mental health support that they need. So this study contributed significantly to knowledge, especially in Nigeria, in Northwestern Nigeria. I also observed that majority of the studies on the mental health of humanitarian workers in Nigeria generally, these studies were based on my literature review. These studies were conducted mostly in northeastern Nigeria, where we have the severity of Boko Haram attacks, and a lot of IDPs are there. So much attention has been given to that area, why fewer researches were actually conducted in northwestern Nigeria, so which leaves the gap. So the study actually contributed in being one of the first and unique studies to assess how the interplay of these predictor variables affect psychosocial well-being of humanitarian health workers. The study is also unique because some of the studies that we see are among general health workers. From my research, I couldn't actually find any study that targeted humanitarian health workers specifically, and also looked at how they struggle with secondary traumatic stress and the strategies to be able to support them when they become victims of this traumatic experience. So these were some of the contributions that the study was able to bring out. All right, so thank you very much. That is the summary of the findings that I was able to get from the research I conducted during my doctoral program. Thank you.